Next, we'll hear from Dr. David Young from the NIH team, who serves as medical director for the natural history study. I think most of you already know him or just met him. If you haven't, please find him and chat with him. So the study is really a cornerstone effort, as I think you all know, in helping us understand RUNX1 FPD over time, how it presents, how it progresses, and what it means for patients and families. Many of you may have heard Dr. Young speak at past meetings, multiple. This might be the fourth patient meeting, third or fourth. Yeah, there's a lot. Yeah, we're not counting anymore. Uh, so where he shared the latest findings coming from the study. And so today he'll revisit a few of those and expand on them. And he really shared that he wants to really open the floor up for questions. And so he'll leave time for that. So Dr. Young, thank you for being here and your dedication to this community and your continued partnership with us. And with that, come on over.
Oh, thank you very much, Amanda. And thank you everybody for being here and taking the time to listen to me. And as Amanda said, I'm going to talk a little bit about a new finding. It's actually some results that are being published just next week in the Journal of Blood Advances about cancer. And I don't think I see any children here, but I will just preface this by saying there is going to be some difficult topics discussed today. I think they're important. I think they need to be discussed, but just so that everybody is aware of that as we go into the meeting or into this talk. But it is my pleasure to be here. And then after I've gotten through that, hopefully we'll have some time afterwards for, a good 10, 15 minutes of question and answers, because I do have lots of information. And as we saw when Dr. Liu tried to present some of the updates from the clinical trial, there's just so much that we're learning about it. And it's just really hard to put it all into a single presentation. And I really think it's important to answer the questions that are on your folks' minds. And Amanda and others were kind enough to provide us with some of that information about what some of the questions you have. But I'd like to hear from you folks as well, and maybe we can talk about some of those things as well. So with that, I will use this button then. Or I'm not using that button. Hang on, wait. Maybe I'm not on the, let me just check one more time. Oh, there you go. All right, so just this is a government-funded operation, a government-funded project, and so these are our disclosures that we present. Most of you, I believe, are probably aware of this, but we do like to start from the very beginning just to make sure we're all on the same page. RUNX1 FPD, familial platelet disorder, is a disorder that happens when genes get misspelled. And as we probably all remember from our biology way back in the day, everything that you need to make a person is encoded in their DNA. And that's just a string of G's, A's, T's, and C's. And these four letters are the things that are used to spell out all the words, what we call genes, to build a person and to run the body. And that's literally the entire human experience. There are some subtleties to that, but that's not as important to that today. But sometimes when the cells are growing and dividing, they have to make copies of this DNA, and they may make mistakes. And we call these mistakes, obviously, the mutations. And if depending upon which cell these happen in, these mistakes can be passed on, obviously, to the cells that come from that cell, but they can even be passed down to our offspring, to our children as well. And RUNX1 has about 250,000 of these letters in them, so it's a big target. And so we do see mutations that happen in RUNX1. And in RUNX1 FPD, what happens is the cells lose control. RUNX1 is what we call a transcription factor, which broadly speaking is a master regulator of the cell. And these transcription factors are important for putting together all the signals that the cells have to deal with when they're coming from the outside, as well as from within the cell itself. And they control when and where and how much of certain proteins are made. They decide what the fate of the cell, whether or not the cell is going to grow, divide, die, change, and things of that nature. And they can even regulate themselves through things called feedback loops. And the important part is that in RUNX1 FPD, the RUNX1 protein is broken. It's either damaged, it's reduced, or it's completely absent from the cell. And so it's unable to do its natural job. And what is that job? Well, RUNX1 is important for controlling both platelets and stem cells, and basically all the blood. They have an effect on all the blood. Loss of RUNX1 affects the platelets, so the body makes fewer of them. And the ones that it is able to make are less active than they could be. And so we have problems with bleeding and bruising. And that's why you can have problems with bleeding and bruising even for folks who have relatively normal counts of platelet counts. So then this is a problem for people who, when they go to an emergency room or things like that, because they may do blood work, say, oh, your platelets are 120. That's a little bit off, but you should be fine. Well, not necessarily, because those platelets don't work as well. But RUNX1 also affects the bone marrow stem cells, which give rise to all the different blood cells that we have in the body. And that includes the white blood cells that fight infections and the red blood cells that carry oxygen. So as a result of this, it creates stresses in the bone marrow that can affect other parts of the body, which can lead to inflammation, anemia or low blood, and infections, and even cancer. And we also know through various studies and through collaborations with groups like the RUNX1 RRP is that it controls more than blood. And as we've gotten to know more and more people with RUNX1 FPD, we've begun to realize that there's a lot more symptoms to this condition than just simply the blood aspect of it. And we're trying to learn more about that too, because sometimes those can be from the day to day, the things that really affect your life and your quality of living. And so to that end, we do have the RUNX1 natural history study, the clinical study. This was started by Dr. Paul Liu, by Dr. Leah Cunningham in the back, as well as by others about 7 years ago. And it's been going over 7 years ago, I should say. It's been going strong since then. And this is some of the information, and we'll also have the contact information for those of you who haven't had a chance to enroll. But basically, what is it? And we like to give the numbers. So how many people have been through this study? We've learned about almost 200 families who have RUNX1 FPD or a change in RUNX1, with over 700 family members in those families. And from that, we've had now almost 570, and I believe it's actually the numbers growing as we speak, of people who have actually who have enrolled to participate in this study. And so I like to say that this is a study is we like to meet you where you are, and your level of participation is the level that you're capable of doing, the level that you're comfortable doing. But any amount of participation in the study really does help us learn more about RUNX1 FPD. So we encourage everybody who can to participate to the extent that they're able. And of those people, we have now almost 300 people who confirmed to have RUNX1 FPD, as well as our 225 family members who don't have it. And they're just as important because it helps us understand things run through families that aren't always RUNX1. And so it helps us to sort of sort out which is RUNX1, which is sort of the quirk of the family. And there's also been another 50 or so people that we've discovered, no, you don't have RUNX1, or we're still trying to figure out exactly what it is you have. And so these are ongoing things. But over 200 people have now visited us, including 60 family members. And we've had almost 160 people have had bone marrow biopsies. And in fact, many of you have had more than one. And we really, really appreciate that. And in fact, we've had a lot of repeat customers. And in fact, we just recently had our first group of people join the 8-time club, with a couple more coming soon. Um, our, our 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 patient of the year being one of them. But we appreciate, even if you only come once, we appreciate even if you can't come. We appreciate just learning about you and getting to know things about it. It really does help. But we want to hear from more of you. As I've mentioned, over 500 people have signed up, and over almost 300 people have the disease. But we think there may be as many people as that, if not twice, 2 or 3 times as many, just within the families we know. We think there are hundreds, if not thousands, of people who have RUNX1 in this country alone and may not even know it. And so we really want to learn about those people. And obviously, we haven't been able to see all the people who've signed up for the study. And some of you obviously have various reasons that you can't, but we would love to know what are the barriers that keep people from being able to either enroll in the study or be able to come to visit us, because we want to help lower those barriers so that we can learn more about RUNX1. And of course, we have to acknowledge, though, all the people who are able to come, and we do appreciate that. Whether it is your first time or your 8th time to visiting us, we really have been learning a lot from you, and we continue to learn things. And we try to take as much advantage as we can of every single visit and every single sample you give us, because it really does help us. We've had a lot of milestones over the 7 years that we've been doing this, including the very first major paper that was published in 2023. And we are now working on a second one that'll probably hopefully get published towards the end of this year, because since that paper was published, we've now doubled the number of people we've met. And so it really has reached a critical mass where we are learning both about all these people as well as how these things affect us over lifetimes. And as I said, you've helped us be productive. This is just some of the papers that we've been able to publish within the last year alone. So it really has been a very productive participation, and we appreciate that from all of you. Now to switch to a slightly more sensitive and difficult conversation, and that is, and we've heard of plenty of people speak about it, that is cancer within RUNX1 FPD, and we know that this is something that weighs on a lot of people's minds, and so it's something that we've been studying very hard and trying to understand, and to understand both how it affects people, what the risks are, and what we might be able to do to help detect and maybe treat it. The work that I'm going to be presenting here is actually, as I mentioned, going to be published just next week in the Journal of Blood Advances. It was actually work that was led by our former post-baccalaureate fellow, who's now gone off to med school, Amr Kajik, but under the guidance of both myself and Dr. Paul Liu, who you all, I believe, know as well. But this is a large collaboration across multiple institutions. And of course, it involves lots of people and getting to know you, all of you, as well as your families. And there's things we can learn from your families, even through the things that you tell us, learning your stories. In those hundreds of people that we've met, and the hundreds of people we haven't met, we've seen lots of different types of RUNX1. There's a large variety. We talk about what kind of RUNX1 do you have? Is it a pathogenic, a likely pathogenic? Is it one of the dreaded VUSs where we aren't 100% certain what it's doing, and things of that nature? But the reality is, across all those groups, we see a lot of cancer. And there doesn't seem to be, at least at this point, a correlation between the specific mutation you have and the risk of developing cancer. We see it in a lot of families. There does appear to be a family history, and I'll mention that in a little bit, but it seems like there is a very high risk of cancer, and we know that. And this is one of the stories, and this is one of the things that brought RUNX1 into people's awareness, is these family histories. That how is that happening? We know that on average, about half the people are 35 or older when they develop it, but that also means about half are 35 or younger. And yes.
Can you just, are all the colors of the people shown matching whether they were pathogenic?
No, that's just matching the type of cancer that they had.
Okay.
Yeah, and this is a slightly older slide, so don't look too deep into it. I believe Paul may have actually presented a slightly newer version just earlier this year, earlier this week. But more importantly, it is to recognize that pathogenic, likely pathogenic VUSs, we do see cancer in all of those. Family history does appear to be a strong predictor. We know that there are some families where it does seem to run stronger than others, but there are some families where it runs lighter. And then, of course, there are lots of people who are the first people in their family to have RUNX1. And so it's difficult to say what's happening in there. But on average, we think there's about a 40% overall lifetime risk of developing cancer for people who have RUNX1 FPD. The good news, if you can call it that, is that it does appear that this risk is limited to blood cancers. There are other disorders where you can get other types of tumors. We are not seeing that in RUNX1, and we have looked, and we're going to continue to look, but we think that this is limited primarily to the blood itself. Now, the big question that we got, one of the things that actually inspired this work by Dr. Kodik, was cancer happens at 35. Do I need the biopsies for my child? Do I need to test my child? Do we need to be doing this much for the children? And the answer is, it's complicated, but probably yes. We know children with RUNX1 FPD can get cancer, and it is a sad fact of the disease, but it is something that happens. And unfortunately, when it happens, it tends to be cancers that look more like adult cancers, myeloid malignancies. And these are difficult cancers to cure. They're difficult ones to treat, and they can be aggressive. So it does happen in children, and we worry about the children as much as we do worry about the adults as well. But we hope that early detection and early treatment of the cancers will give us the best chance of fighting it and beating it, and actually getting a lasting and lifelong cure so that they can go on to live a healthy lifestyle. But when we look at when is cancer happening in people who have RUNX1 FPD, when we look at the age that someone was diagnosed with a malignancy like a leukemia or a CMML or things of that nature, we see two different peaks. We see the adult peak like we expected. It happens at a younger age than the general population, but it is there. But we do see a peak of children who are also getting cancer, and that's what worries us about saying, oh, it only happens at 35. No, there are a good number of people that it's happening at a younger age. And so we really need to keep a close watch on children. And the other thing to realize is, although we talk about the bleeding and bruising, it can be harder to really tease out in children as to whether or not that is actually RUNX1. So we need to test the children so that we know and not just simply rely on how they look. And that's just one of the things that we've really learned from this study. And when we look at the accumulated risk of developing cancer throughout lifetime, and this is showing basically that this case is piling up as you go from birth through about 75 years old to 80 years old, we see that there appear to be three different phases. The first phase happens in childhood. There are a group of cancers that are occurring and piling up until about the age of 18 to 20. Young adulthood, fortunately, things aren't completely quiet, but they do settle down, and we see a lot less cancers happening in those ages, especially in the early 20s and 30s. But then beginning around 35 and usually by about 45, we see the rate of cancer start to go back up again and start to accumulate again. And so overall, by the time you reach about the age of 70, the risk of developing cancer is between 20 to 55%. We say about 42 is the rough estimate. And importantly, by the age of 18, there's about a 4 to 11, on average 9% chance of children also developing cancer. So almost a 1 in 10 chance. And that is a pretty big risk. So that is why it's important both to know if children have RUNX1 and to make sure that we're testing and monitoring them closely. We have compared it with other groups. We've compared it to the general US population, and obviously this is much higher than we see in the general population. It is similar to other diseases like Fanconi anemia, where there is a risk for developing cancer. Now, I will say Fanconi anemia has a risk of developing other cancers too, and this is only looking at the blood cancers. But we see similar lifetime events. But RUNX1 is kind of unique in this pediatric bump, this little accumulation at a young age. And when we look at the year-over-year risk of developing it, what we see is that at a very young age, the red lines here, the risk is high, even basically from birth. Whereas in other diseases, it continually grows with life, and RUNX1, it starts off high. And this was shocking and this was upsetting for us, and obviously is not something we wanted to tell the community, or we're happy to tell the community about, but it is something we think that the community needs to know, that it is there, the risk is there. And that is why we have been pretty aggressive in getting this information out. So that raises the question, well, okay, that's frightening. Can we detect the cancers early and maybe do something about it? And so I know we've been talking a bit about somatic mutations and things of that nature in RUNX1. And the reality is, as we age, our bodies make mistakes. And everybody, whether they have RUNX1 or not, develops small mutations in their blood. And these accumulate with time. And sometimes, most of the time, those do nothing, but sometimes they can cause changes. We see the same thing in RUNX1 FPD, but it happens at a lot frequent in an earlier rate than we do in the general population. And we see mutations like BCOR and TET2 are the most common ones that we see. And we see lots of other ones too. And right now, what we are really trying to do is ask, are there certain mutations that if we see them, those are red flags that we should be watching out more carefully for? So far, no. When we first started doing this work, we saw a lot of people have BCOR. And as I said, about 1 in 5 people will have BCOR. And probably most people will have BCOR by the time they reach older age. But that doesn't seem to matter. In fact, if anything, it seems like that's the body trying to adapt to RUNX1. We don't exactly understand it, but it doesn't seem to be a red flag. But there might be other genes that when you start seeing mutations in those, that we have to be more worried about. And the problem is, the real kicker is that children seem to be less likely to develop these mutations before they develop cancer. And so even though we have these great tests and we're excited about them because maybe we don't need to do all those biopsies, they might not be picking up the early warning signs for children like they would for adults. So that is an unfortunate wrinkle in the situation that we weren't expecting to see. But we do know that if we keep tracking these and the patterns are probably the most important thing. So if you are getting the tests, keep getting them, and we recommend this testing for everybody. So what can we do? So we recommend that everybody be tested. If someone in the family is diagnosed with RUNX1 FPD, and in fact, that's why you're in this room today, we recommend that everybody in the family who could be potentially affected also be tested as well, and then slowly work your way out through the family trees. We recognize not everybody wants to be tested. You can't be held responsible for what Uncle Jim wants to do or what Aunt Mary does, but at least let them know, and then they can make the decisions on their own, and then make sure we're getting our children tested, our siblings, and things of that nature. Monitoring by CBCs are important. I hear a lot of people say they get quarterly, and that would be our general recommendation. We think at least 2 to 3 times a year, but more than that, it's probably a little bit better. More than quarterly is probably too much, though, and you'll probably be running around worrying about small little fluctuations that don't mean anything. And then also the bone marrow biopsy. We do recommend children get a bone marrow biopsy because there are risks involved, and because it does involve anesthesia. We are okay And we think it is okay to wait until children are a little bit older, maybe about 3 or 4 years old, before they get that first bone marrow biopsy. But it helps to establish that baseline, helps us to understand what the bone marrow looks like, helps to look for any changes, and then that allows us to follow them. And then if you've had a few bone marrow biopsies for a few years in a row and they're looking stable, maybe we can start spacing them out. We're trying to figure that part out yet, but we haven't quite gotten there. And so everybody asks, well, what do I look for? Well, talk to your doctor about anything. It's never wrong to ask for a blood test. If you have new or worsening bruising or bleeding, get a CBC. It's the most important clue we still have in our back pocket. If you have fatigue, if you're tired, frequent infections, changes in your skin or your eyes, changes in your abdomen, swelling, bloating, distension, changes in your weight, for good or for worse, and recurrent fevers are all things that you should talk to your doctor about. And it's never wrong to talk to your doctor. It's never wrong to reach out to us either. We're always here ready to help. If you have questions, there's some things your doctor can't answer, we're here to help too, and to talk to them and help you guys figure out what's the next best step, what's the next test we should do, what should we be looking for. And so with all that, I was very honored at the award last evening. That was a very surprising honor, but this is a group effort, and I wouldn't be standing here without the help of all these people, including Dr. Liu, of course, who helped set this up, but everybody else on the clinical team who hopefully you will all get a chance to meet when you come to the NIH, as well as also the NHLBI team. As we are trying to move into looking at clinical treatments for RUNX1 FPD, we're going to be relying on them as well to try to run some of those clinical trials. And of course, all the people both within the NIH as well as outside the NIH, some who are here today, some who couldn't make it, some who we really have gone unsung. And of course, all the family members, all the patients, all the doctors who referred them, and everybody else, and all the RP. We couldn't do any of this without all those people, and we are very grateful for that. Went a little bit longer, but I appreciate your attention, and I'm happy to answer any questions if you have them. Thank you. Please.
The NIH study, if you've already had a transplant, what would bone marrow aspiration be able to?
In that case, we wouldn't probably recommend it, require it. Now, you might be doing them for monitoring, especially shortly after the transplant. So a lot of times they'll do them for a few years out until they can really assure themselves both that the transplant's kept and that things are going well and you're not having problems. But from our standpoint, there might be things to learn, but we haven't really figured it out. So we're not asking it at that point. But checking blood, looking at things like that, and just learning about how things have gone for the transplant. That's one of the questions that's come up over the course of this conference is what happens to people after transplant? Because yes, in theory, the RUNX1 is now off the table from that standpoint, but it's still something that happened and we want to know so we can help people understand what are the risks and benefits for getting transplant if they're facing questions, especially things like preemptive transplant. Yes. No, it's fine.
And so the question was, is that a microenvironment problem? Most people have heard in the room that there's a seed, kind of like a plant a garden, right? You want to grow tomatoes, you want your soil to be, healthy, and you want the seeds to be healthy. And so if you are getting a bone marrow transplant and you have the seeds, you're not changing the soil, that they're in with that transplant. And so the kind of microenvironment is something that I talked to some of the other scientists about in the last couple of days of, kind of looking into. So I think that anybody wants to get bone marrow, I don't think we need to turn it out.
Yeah, no, we won't turn out anything. And I see there are a couple questions online. Monica asked the question of whether or not children tend to get lymphoid cancer versus myeloid. And that is correct. In general, children have ALL more than AML. And that still is kind of the case in RUNX1 FPD. We do see more ALL in children, but there's let me rephrase that. We do see ALL in children with RUNX1 FPD, but we see a lot more AML than we would have expected. In fact, it kind of flips to the point that the children almost look like adults in that regard. We don't fully understand how that's happening. It probably has to do with both the gene as well as the changes that are being driven by the gene mutation. But yes, we do see the AML, and that is one of the reasons that we get worried, because we know that these are difficult diseases to treat when they pop up in adults, but also in children as well. I think. And then Georgie, if CBCs are important clue, what aspects should we as patients recognize as important? Um, Bleeding, bruising, anything. There's really never a wrong time to get a CBC, to be honest. We might find ourselves fretting over a number, but you can recheck it in about another couple of weeks, and things often will go back to normal if there's nothing really going on. If there is something going on, as we've seen with some of our family members, then we know and we can track that and keep following it too. So there's really no bad reason, but things like increased bruising, weird bruising, the petechiae in places that you weren't seeing before, now all of a sudden all over the chest or all over the back, those are some of the things that we would definitely want to look for. But if you're really tired or really having trouble with working with stairs or things like that, or some says you look really pale, it might be just a good idea to reassure yourself at a minimum. Sometimes when we get colds, if we get COVID and things like that, or we get even the flu, our counts will drop as well. And so checking a CBC after them, we might see some changes that might cause a little bit of anxiety, but usually those will get better in the course of a few weeks to a month. And so we'll know, we'll be able to track it, and we won't have missed something. And if there is something going on, we'd rather know and deal with that stress. And it is a stressful thing, but to not know and then to miss that window when we could have intervened earlier and that before it progresses to something even more severe.
Dr. Young, I think Georgie was curious about which specific counts on the
Oh,
CBC are of
all
interest. All of them.
Platelets are probably the biggest indicator because they're the disease. So if they're going up or down, they sometimes give us the earliest clues. But we like to look at the different types of white counts. So when we get that CBC, I should say it's CBC with differential. So we look at the different types of white blood cells, because if there is a cancer, sometimes we can actually see them that way too. But anemia could be the first signs of problems. Anything that test really is a very powerful test. Even though we say it's just a CBC, it tells us a lot about how the bone marrow is doing.
Now with the CBCs, like for instance, my CBCs, they don't go down real fast, but I've noticed like in the last 3 or 4 years, they're slowly stepping down.
Mm-hmm.
Is that something to be concerned about in the future, or do you even know?
As we age,
Mm-hmm.
things will change. It's the sudden drops that do make us worried, probably the most. But a trend in a given direction could prompt us to want to check a bone marrow again and keep an eye on it. It also depends on what going down is. If it's just a slow, steady, age-related one, that might be just normal aging, or it could be a bad sign. Mm-hmm. That is a difference. It is a difference, and so we would want to keep an eye on that. But you are keep doing what you need, so yeah. And this is the difficulty though with these sort of tests, because they are a bit of a blunt object, in that we can find ourselves fretting over small little fluctuations, which aren't. And the platelet counts, a normal platelet count is anywhere between 150 to 300. That's a huge range. But a 10-point drop is probably not a big deal. A 20-point drop that keeps happening over and over and over, that could be a problem. Yes. Yes.
Yeah, I have Frank Larson, and
Thank you. Oh, no. Yeah, no, go ahead.
Yeah. And so if I've seen like more severe bruising, but like my CBC levels are like coming back fine or they're not concerned, like what would you recommend someone to do?
We get that from time to time.
Yeah.
And there are people like, oh, and then we'll look and like, oh, that looks good. I mean, continue to watch it, continue to follow it. Usually the bruising and bleeding, or bruising, I should say, from day to day, is no one likes it, but it isn't usually life threatening. So as long as it's kind of just bruising, we would keep watching it and make sure there's nothing else. You'd want to make sure you're not taking a medicine or something that might be interfering with your platelets or what have you, and just keep a close watch on it. if you're starting to have more and more severe bleeding, your doctor might want to do a more extensive bleeding workup to make sure there isn't something else going on. RUNX1 causes bruising and bleeding, but other things can too. And unfortunately, as we see more and more people, we will see people who are just unlucky and get something else on top of it. And so we wouldn't want to rule that out or blind ourselves to something else that might be treatable. So it's important to keep an eye on that too.
So I had a question back to biopsies, everyone's
Yeah.
favorite subject. I owe my transplant doctor another biopsy. I'm
Sure.
about 2 months behind, finding excuses not to do it. But when I go do it, which hopefully will be in the next couple weeks, should I tell them to pull an extra vial for you guys at NIH? Does that matter? Does that?
If they're willing to do it, well, we'd be happy to accept it. At a minimum, we could do some basic testing and look at the genetics. One of the things we are trying to really understand is if we can detect really subtle evidence of the old bone marrow and things like that. That may not be clinically relevant, but might tell us things about the disease, about RUNX1. And as I said, we're never going to say no to a sample because who knows, we might learn something that we weren't looking for. And that has been the story of both the RUNX1 program itself and science in general. Sometimes you are just there in the right time and looking, and because you were looking, you learn something.
And kind of tying into that, I had a blood draw, my quarterly visit back in November, and I had COVID like the week before. And so I took the Paxlovid, knocked it out pretty quickly. It was like 4 days, so I seemed to handle it fine. But in that test, my platelets went up to 170. And then since now, I'm back down to my 120s, which was where I've typically been. So either there was maybe a bad test, maybe, or is there some relation to that?
Either things can happen. It can either cause, depending on how the effects it has upon your bone marrow, it can suppress the bone marrow and your counts can drop. But platelets themselves, especially platelets that are functioning normally, are part of the inflammation response. And so when there is inflammation, especially something like COVID or something like that, you can actually see the counts go up. That is a somewhat normal response to inflammation. We call those the acute phase reaction. But either one could happen. Either one could be explained by it. And that's why we just recommend, well, okay, that was a little off. Let's double check in a couple of weeks to make sure it goes down. And we have seen with patients who have COVID and other pretty significant illnesses, the tail on that can last for weeks to months. And so it might take a little while for the counts to normalize again. So that's the difficulty of checking, because then you have to figure out what to do with the data. But as I said, it's better to know than not.
Hi,
Yes.
David. I'm actually more curious and would like to know more about. I know most of us, if we have the RUNX1 gene and it told that, it's these second supposedly hits, RUNX1 itself doesn't cause cancer. You get these second hits that cause cancer. But from your chart, it looks like most of us are running around with these supposedly second hits and do not have frank cancer.
Yes.
So actually, I'm just more curious about the data of at what point do any of these secondary mutations would cause the frank cancer? And I'm really interested in what
That's the question.
I know, and I'm really interested in your data to find out, say like you have a B core and you're sitting around 10%. If you guys know at like what percentage it would get to.
And we've seen some people with some really large B core variants where it seems like basically half of the blood is being made by a single clone, as it would say. And that's strange. And yet it stays there for years and nothing changes. We've seen a good amount of people who, and one of the things is both the sad but nice thing about having been this trial running or the study running for so long is we're now seeing people develop their cancer while we're watching them. And that's really, it's sad, but it's very helpful because we can really understand how things evolve. And we'll see like, oh, they had this big B core. We were worried about this clone. And then it kind of got pushed out of the way and the cancer came from somewhere else. And so it's difficult to say. And that's why one of the things that we really worry more about than anything is if we start seeing changes. Oh, these clones are growing, or it seems like something is taking up space, even though we can't really detect it because other clones are being shoved out aside and they're getting smaller, or the numbers are getting a little strange, or now we're starting to see more and more different little clones, even though maybe not one specific one. Those could be signs that the bone marrow is very much under a lot of stress. And so that stress is either because there's something going on, or it could be setting you up for something to emerge out of it as the body just tries to compensate, and all of a sudden the wrong correction is made and now you have cancer. We don't fully understand, though, the sequence of events. There are diseases out there. One that we mention a lot is Schwachman-Diamond, because there are a lot of similarities. But we know that when in that disease, as we monitor, they also do monitoring for somatic mutations. If you see a certain set of mutations, that's a warning sign that you need to go to transplant now before the cancer comes. We haven't seen that in RUNX1. We
Okay.
are hoping we do find something, and it doesn't seem like it's going to be this panel that is better at detecting that'll give us that warning. We haven't found it yet. There are a couple mutations that we do see a little bit more frequently than others with cancer. We're still trying to figure out if that's a real association or if it's just a coincidence because we just don't have the numbers yet. But we haven't really seen a strong signal, and that's what we were really hoping for, because we see that in other diseases. And it may just be because RUNX1 is a disease that isn't, you're right, we don't think that the RUNX1 mutation in and of itself is what's causing the cancer per se, but it's creating a very hostile environment in the bone marrow. The marrow is aging quicker. There's a lot of inflammation. I mean, we know about all the inflammation you see around the body, people with eczema and allergies and things like that, but it can also be happening inside the bone marrow, and that places a stress on the bone marrow, and it basically ages the bone marrow quicker. And so that might be why we are seeing these. And so it's just more of a chance. And the RUNX1 helps shape what that looks like, but it isn't necessarily driving it specifically. We're really trying to understand that part. We don't quite know it yet.
Yeah, I'm just saying from a patient standpoint, like on paper, if I show another doctor and this is my paper and they're like, and then I'm walking around, hey, what's up? And they're like, on paper, it's like, why do you look so good when on paper you look like you should have
The more we
more
look,
than,
the
yeah.
more we find, and the more stressful it can be. And I wish we had more clearer answers. I'll just say that. And we all wish we had more clearer answers.
So, but thank you for everything that you guys are doing because I'm very interested in
It's
what
our
you guys come
pleasure.
up with.
I know there are a ton of questions. There are two more people in the room that I've met eyes with.
Okay.
I'm gonna
Sorry, I'm stealing from.
Oh, you got your okay. Well, I saw you. I did see you, but okay.
Okay, my question is, if we're supposed to be having regular CBCs, do you want those sent if we're a
We'd love to
participant
get
in
them.
the study?
It helps. At a minimum, at least lets us see what the trends look like over time. Yeah.
Okay.
Like I said, we'll never say no to a sample. We'll never say no to data. We love it.
Okay, great. We'll do one more, and then there will be time during the research showcase to come
Yeah,
talk with him
I'm
as you
happy to
have
chat.
more questions. Okay.
I'm just curious if you have seen any connection between an increase in cancer for people who have like a deletion versus a mutation.
That is a really good question. We thought maybe we would initially. We haven't seen it yet. Now, we've seen a lot of cancer. Fortunately, it's not that much. So maybe there is a small association. But generally speaking, it does seem like the risk is spread pretty evenly across all the different types of mutations. And one of the things, and this is one of the reasons that we love meeting people and learning more about your family, not just you, is that in one of the parts of the study we did was we looked through family trees. And we can't tell everything. We can't do genetic testing on all those people, but we know at least that mutation is running. And usually we can trace it and be pretty confident what we're seeing. And so that did help us to really get a sense of even the more and more data and really add some data on. And even then, the trends seem to be similar. If the mutation is deleterious, the word pathogenic is the word that a lot of times we use because that's saying certain, we know for a fact it's broken. But if we think it's broken, even if it's a VUS that we haven't been able to prove conclusively that it's broken, we see the risk there. It's only in patients who have changes that aren't causing problems with RUNX1 itself. We don't really see the association. So it doesn't seem to be which one, just as long as it's damaging the function of RUNX1.
Yeah, if it's okay. And I also just wanted to commend Dr. Young of doing an absolutely amazing job of taking 10 years worth of data and putting it into an understandable 30 minutes. So that's great. I just wanted to add, if it's okay, that in this spirit of advocacy, as a community, as families, and also as individuals, that some of just in the context of variability in bone marrow. So some people are like, oh yeah, take my marrow, no big deal. They barely need lidocaine, and other people have bleeding and bruising and discomfort sometimes for weeks. And I would just personally like everyone to feel empowered to ask for exactly what they need for their comfort. So for the people who need lidocaine only, that's great. There are also options for conscious sedation. For children, they get general anesthesia. And please, if you're having problems with pain or discomfort, please ask your providers for recommendations for preventive things like Amicar or DDAVP or conscious sedation if you need it, so that everyone can be as comfortable as possible.
Yeah. And I'll also say for the folks online, I'm seeing some really great questions. I don't want to derail this any longer, so I'm going to stop here. But my information here is on the screen. Please feel free to email me, email any of our team. We're happy to talk with you. I also have Natalie's business card because she's our great point person. Katie is here as well. My business card is a disaster. I'm very out of date, so I need to get a new one. So I'm not going to share that one. But I'm happy also to answer questions. And if there are questions that they can't answer, they're happy to share with us. There's never a wrong time to ask us questions. There's only a wrong time not to. And so we're always here for you guys. And again, thank you so much for your attention, for letting me go a little bit over time.
Thank you, Dr. Young.